Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on this week's video. On this week's video, we're in our 7th and final session of our ongoing series entitled Orthopedic Essentials for the Qualified Medical Evaluator. And the purpose of this series is to help you as a qualified medical evaluator begin to focus more on your own observations and your own findings that constitute true positive physical examination findings in the face-to-face evaluation with your examinee. You know, the AMA guides tell us that the permanent impairment ratings that are described in the AMA guides are based upon positive objective findings in the physical examination, and it seems that at times we many times become distracted by the examinee's subjective reports of pain and subjective reports of limitations with activities of daily living in arriving at our permanent impairment opinions and conclusions for the examinee. But the AMA guides, while they do not completely discount the importance of subjective findings, they encourage us and they admonish us to focus on the true positive objective physical examination findings. And it seems that there's great confusion as to what constitutes true positive objective physical examination findings in the face-to-face evaluation, and thus the need for a program of this nature. And through sessions 1 through 6 of this program, we've talked about all manner of observational findings and physical examination findings, especially with focus on the neurologic aspect of the examination because of the heavy emphasis that the AMA guides place upon the importance of the neurologic aspect of the physical examination. And in today's discussion, I have a fascinating discussion regarding the joint examination of the spinal exam in Chapter 15 of the AMA guides, the upper extremity exam in Chapter 16 of the AMA guides, and finally the lower extremity exam in Chapter 17 of the AMA guides. But before we get into today's discussion, let's just take a couple moments to recap the program as far as we've come through sessions 1 through 6. And then we'll get into today's discussion. In session 1 of this program, we talked about and we defined pain. Now, because you can expect examinees in the qualified medical evaluation to present to the face-to-face evaluation in pain, it's important to have a good understanding of what pain actually represents. So according to the Merriam-Webster dictionary, pain is defined as an unpleasant sensory and emotional experience. So it's important to recognize and realize that pain has at least 2 components. It has a sensory component and it also has an emotional component. So as a qualified medical evaluator, it's important that you be able to separate and compartmentalize those aspects of your examinee's descriptions of pain that refer to the sensory aspects of pain, and those components or aspects of the examinee's description that are totally and completely emotionally based descriptors. And as a qualified medical evaluator, it's important to be able to focus on the sensory aspect of the examinee's painful description. So that was the first part of the definition of pain. The second part of the definition of pain, equally important, tells us that pain typically leads to evasive action. And it's this evasive action that's going to form the basis for what we refer to as the true positive physical examination findings. Evasive action. True positive physical examination findings are characterized by some form of evasive action. Now, in the physical examination, evasive action is nothing more than some manifestation of the flexor withdrawal response. And if you remember the flexor withdrawal response, you'll remember that it's reflexive. It's not cognitive, it's reflexive. It's automatic, and it's a form of evasive action as the examinee attempts to reflexively move away from pain. So in the presence of true pain, when your physical examination maneuvers truly provoke actual bona fide pain, the examinee will demonstrate some form of flexor withdrawal response, some form of evasive action in order to get away from pain, and that's going to form the basis of our true positive findings on physical examination. In session number 2, we talked about how different injuries, for example, injuries to muscles, injuries to ligaments, injuries to bone, injuries to vascular tissues, each of these different types of injuries have a characteristic and predictable pain pattern, and the examinee will use characteristic and predictable descriptors in describing their pain. So it's important that you understand these different types of descriptors and compare the known pain patterns with these various tissue injuries to the examinee's descriptor of their painful symptoms. And it's important that there be consistency between the examinee's description of pain and the known and predictable pain patterns associated with these different tissue injuries. In session 2, we also talked about 7 types of cumulative trauma or repetitive stress pain. And we also talked about the 4 different types of pain previously used in the workers' compensation system related to the 1997 Permanent Disability Rating Schedule, wherein we employed the words of art to describe the subjective factors of disability. And those words of art included minimal pain, slight pain, moderate pain, and severe pain. And each one of those descriptors of pain describes a different impact of the pain on the ability to perform activity. So for example, a minimal pain is pain that is there, it's a nuisance pain, it's an actual bona fide pain, but the pain is not significant or severe enough that it interferes with the activity that causes the pain. So if we're thinking about physical examination maneuvers, when the examinee reports pain during a physical examination maneuver, but that pain does not interfere with their ability to fully complete the physical examination maneuver, in other words, there's no manifestation of evasive action that interferes with the ability to perform the physical examination maneuver, we refer to that as a minimal pain. Now, slight pain, moderate pain, and severe pain describe increasing impact of the pain on the ability to perform activity, whereas slight pain slightly interferes with the ability to perform the activity, moderate pain more significantly interferes with the ability to perform activity, and severe pain precludes the performance of the activity. So with severe pain, the pain is significant enough that the examinee demonstrates evasive action through some form of the flexor withdrawal response and is unable to perform the activity that causes pain. This is important because the AMA guides tell us that an impairment that causes no impact and no functional consequence and no loss of ability to perform activities of daily living qualifies for a 0% permanent impairment rating. Many examinees are being overrated for permanent impairment when in actuality their pain is nothing more than a minimal pain. In video number 3, we talked about pain and its relationship to activities of daily living. And we said that pain can interfere with activities of daily living, but most examinees that you're going to encounter in the California workers' compensation system do not have true limitations to activities of daily living. Now, that does not mean that examinees will not report to you that they have pain with activities of daily living, but pain and limitations with activities of daily living are different things. So examinees who have true and bona fide pain with activities of daily living will generally present to you with minimal pain, meaning that they have pain with climbing stairs, they have pain with walking, they have pain with gripping and grasping and all these different activities of daily living, and yet they're fully able to complete and perform the said activity. So in that sense, the pain is minimal pain only, and the pain, however severe it may be by their own descriptor, does not truly interfere with activities of daily living. Now, for examinees who do have true limitations to activities of daily living, each of the limitations in the activities of daily living that are described in the AMA guides can only be caused by a finite range of conditions and or injuries. And each of the limitations to activities of daily living should be accompanied by positive objective physical examination findings that supports and corroborates the examinee's description of a loss of function for the particular activity. Okay, so very interesting concept. So it raises the necessity of doing a thorough and comprehensive and exhaustive assessment of activities of daily living with each and every examinee. And in my opinion, and it's my recommendation to you, that the assessment of activities of daily living be done in the face-to-face evaluation with the examinee. Only in this way, meaning interactively, in the face-to-face evaluation, can you discuss with the examinee interactively each of the various activities to arrive at a true determination as to any bona fide limitations with those activities that the examinee may truly have. So it needs to be done interactively in the face-to-face evaluation, and in my opinion, this is not something that can be done through the use of a checkbox form. Finally, in our last session on session number 4, we talked about objective findings in the observation of the examinee. So in beginning the physical examination with your examinee, the first step to any physical examination involves simply observation. And there are many true positive physical examination findings that you can discern and detect simply through observation of the examinee. So we talked about the various forms of pain behaviors that are described in the AMA guides. And we said that with the exception of moaning, crying, and otherwise complaining, most of the pain behaviors are nonverbal forms of communication that you can pick up without even saying a word to the examinee, and you can notice these true positive observational findings when they're present. You can notice these within the first 10 to 15 seconds of observation of your examinee. And then we talked about some of the other true positive observational findings that you may come across with your examinee, such as scoliosis, scars, various asymmetries, limb length discrepancies, and the like, that you can pick up simply through laying your eyes carefully and observing the examinee carefully in the face-to-face evaluation. And then in video number 5, we began our discussion of the neurologic aspect of the physical examination, and we talked about physical examination procedures for the assessment of the spinal nerve roots, and then also the named peripheral nerves of both the upper and lower extremity. And the main conclusion from video number 5 was that sensory and motor testing, while we rely heavily on our findings in physical exam on sensory and motor testing, sensory and motor testing is largely unreliable because it relies heavily upon examinee subjective reports. Whereas in the neurologic examination, reflex testing is the most reliable measure of function because the findings on reflex testing are truly objective physical examination findings, whereas sensory and motor testing are largely subjective findings. So in the presence of normal reflexes, normal brisk +2 reflexes, what we consider to be normal reflexes, when you have normal reflexes, that tells you that many structures are functioning normally. Many structures are functioning properly. So while the examinee may give you subjective statements of reduced sensory function and reduced strength on manual motor muscle testing, those findings, those subjective reports by the examinee, are obviated and negated in the presence of normal reflexes and normal reflex testing. So you can hang your hat on and you can rely on your findings on reflex testing in coming up with your opinions and conclusions on the function of the spinal nerve roots and the named peripheral nerves, because reflex testing is the one truly objective physical examination procedure that we have in our doctor's toolkit. And then finally, in our last video, video number 6, we started to focus in on the anatomy and on injury and on physical examination findings for the named peripheral nerves of the upper and lower extremity. And we talked about the 3 grades of nerve injury, including neurapraxia, axontomesis, and neurotomesis. And we talked about the role of the myelin sheath and the endoneurium in determining the outcome of each of these grades of severity of injury to the peripheral nerves. We talked about how Wallerian degeneration, at least in the case of axontomesis, can result in a restoration of the anatomy of injured neurologic structures. And then we talked about the sensory, motor, autonomic, and reflex findings in bona fide peripheral nerve injuries. And we introduced a new topic known as neural tension signs and the role of neural tension testing in assessment of upper and lower extremity peripheral nerve function. And that brings us to today's discussion. And in today's discussion, we want to shift our focus away from the neurologic aspect of the physical examination to now a more focused attention to the joint examination of the spine and the upper extremities. And we're going to begin by going into great detail on the positive physical examination findings associated with injuries to the contractile and non-contractile tissues of the spine and the extremities. So we'll talk about positive physical examination findings to muscles and tendons, and we'll contrast those with the positive physical examination findings that we would expect to see in injury to inert structures in and around the spine and in and around the extremities, with focus on the ligamentous structures. And then we're going to conclude our program by talking about true positive physical examination findings in the range of motion and manual muscle testing portions of the physical examination. Now, it would be great to be able to go into a complete physical examination analysis, but of course that would take many hours. So in today's discussion, I want to just limit our focus on 2 of the most common tests that are employed in the physical examination with our examinee, and that has to do with range of motion testing and also manual muscle testing or strength testing of injuries in and around the spine and injuries to both the upper and lower extremities. So with that as our introduction to today's discussion, let's begin by talking about injuries to the contractile versus non-contractile structures. So as we get into our physical examination of the spine and the upper and lower extremities, and we examine the joints through range of motion and manual muscle testing, we're going to see that pain can be elicited from any combination of the contractile tissues, the nervous tissues, and the so-called non-contractile or inert tissues. And we'll review each of those. So the contractile tissues include the muscles, the tendons, and their attachments to the bone. And they can elicit pain as tension is placed on these tissues by either stretching or by the forces generated by contraction during manual muscle testing. So if you just review the anatomy of the contractile tissues, Note here that we have a cross-section of a local muscle tissue. This could be, for example, the biceps muscle. And recall that in reviewing the anatomy of a muscle, we have here the smallest functional unit of muscle known as the muscle fiber. And a muscle fiber represents one single individual muscle cell. Muscle cells are elongated cells. They're so elongated that we refer to them as muscle fibers. So here we have a bundle of muscle fibers contained into a group known as a fascicle. Now, interesting is that each individual muscle fiber is surrounded by connective tissue known as the endomysium. So here we have many, many muscle fibers, each surrounded by their individual endomysium, and then the bundle itself is surrounded by its own connective tissue known as the perimysium. So we go from endomysium to perimysium, and then when we consider a group of fascicles, all these fascicles contained within this cross-section, all of these fascicles are themselves surrounded by connective tissue, and that is known as the epimysium. So these three layers, or these three levels of connective tissues, the endomysium, the perimysium, and the epimysium, these are arranged longitudinally along the length of the muscle fiber. And these connective tissues continue uninterrupted to become the tendinous structure of the tendon. Now, tendons have their own cross-sectional anatomy, different but the same as muscle. So if we took a cross-section through here of this section of the tendon, it would look similar to this cross-section of the muscle in that there would be individual functional units, just as muscle has individual functional muscle fibers, the tendon has individual functional units. It would have individual functional units collected up into fascicles, just as the muscle belly itself is collected into fascicles. And then the multiple fascicles would be surrounded and collected by a connective tissue layer. And the tendon has a similar structure. So all of these connective tissue structures contribute to the structure here that connects the muscle to the bone, and this is the section that we refer to as the tendinous structure. But it's important to remember that the tendinous structures are continuous all throughout the circumference of the muscle itself. Now, this region here of the muscle and tendon of this contractile unit consisting of muscle and tendon, this is known as the myotendinous junction. And this is the weakest portion of this contractile unit. And this is the region wherein many muscle and tendon injuries occur. Muscle and tendon injuries also occur here at the junction where the tendon attaches onto the bone. And it's important to note anatomically that all of these connective tissue structures, the epimysium, the perimysium, and the endomysium, and their tendinous equivalents down here in the tendon, all become continuous and contiguous with the periosteum of the bone. So this is an area here also where injuries to the contractile units can occur. Now, with nervous tissue, we can have pain emanating from the nervous tissues and their associated sheaths, because nervous tissues, whether we're considering range of motion testing or manual muscle testing, can have tension put on them by either stretching or compression. And similarly, the inert tissues such as joint capsules, ligaments, bursae, blood vessels, cartilage, dura, etc., they also can have tension put on them similarly by stretching and compression. So let's go through an analysis of the difference between injury to contractile tissues and the positive objective findings that we would expect, and compare that to injuries to inert or non-contractile tissues and the positive objective findings that we would expect with those. So let's define these injuries. And I have here for you a table that describes injuries to the contractile tissues through this section of the table, and injury to the non-contractile tissues through this section of the table. So over here we're talking about injury to muscle and tendon here. Over here we're talking about injury to the ligamentous tissues as an example of inert tissues. And then we have in here a middle category which we'll explore regarding injury to the tendon structure itself. And we're going to talk about specifically tendinitis and tendinopathy because of the frequency with which we see these types of injuries in the workers' compensation setting. So let's define each of these grades and types of injury. Well, if we're talking about the contractile muscle and tendon injuries, we grade those injuries by grading them as either first degree, second degree, or third degree strain injury. Similarly, with the ligamentous structures, we also define those by the same grading system, first, second, and third degree injury. So with a first degree injury of contractile or non-contractile structures, we see that we have a few of the muscle fibers are torn, or a few of the ligamentous fibers are torn. Not many, but less than 50%. When we get to about 50%, we start to grade the injury as a second degree injury. Whereas with a third degree injury, that represents a complete rupture of either the muscle or the tendon or of the ligament. And with regards to the muscle or the tendon, this rupture can occur, generally occurs at the myotendinous junction, but can also occur at the junction of the tendon with the bone. Now, the mechanism of injury regarding all of these types of injury have to do with overstretch and or overload. Now, of particular interest are the tendinitis and tendinopathy types of injury. With tendinitis, tendinitis is an old term that we use to describe inflammation of the tendon. That old term is now being replaced with the more updated and more useful and more descriptive term known as tendinopathy, whereas tendinopathy now refers to intratendinous degeneration within the substance of the tendon. The term tendinopathy is replacing the term tendinitis because histologically, when painful tendons are examined under the microscope, it's found that there is little to no inflammation present. In other words, the old concept of inflammation to the tendon is now being replaced with microscopic findings of intratendinous degeneration. And the term intratendinous degeneration refers to the many sequences of events that result in a weakening, a structural weakening and a structural atrophy of the tendon itself, such as replacement of type 1 collagen fibers with weaker and more disorganized type 2 and type 3 collagen fibers, such as a reduction in the number of tendon cells known as tenocytes that are present within the tendon, such as a weakening of the extracellular matrix of the tendon. And so we're seeing under the microscope that the whole tendon itself is degenerating, again, due to overuse, due to overstretch, and particular due to aging. It seems that tendons, as they age, unless they are continually properly mechanically loaded, tendons, like muscles, will undergo a degenerative process. In muscles, we refer to that degenerative process as sarcopenia, and it's important to note that with aging tendons go through a similar degenerative type of atrophic or degenerative process. With first degree strain and sprain injuries, we're going to see no or minimal strength deficit, but we're going to see increasing strength deficit with the second and third degree strain injuries and also the second and third degree sprain injuries. And in this case, weakness is generally due to reflex inhibition, as the examinee experiences pain due to loading the contractile and due to loading of the non-contractile structures in and around the joint. They will experience weakness due to reflex inhibition. So the AMA guides tell us that weakness in the presence of pain does not qualify for permanent impairment, and this is a perfect example of that. Most of this weakness that we're going to see with these muscle tendon injuries and ligament injuries is due to reflex inhibition, and while the examinee may qualify for permanent impairment due to other aspects, they will not qualify for permanent impairment due to loss of muscle strength, because the muscle strength is due to pain. Now, muscle spasm may or may not be present in these sprain-strain injuries, with the exception of the second and third degree strain injuries, where that muscle will go into moderate or major muscle spasm, and this will cause the examinee great pain upon movement of that muscle. There may or may not be swelling present with the first degree sprain and strain injuries, and swelling becomes increasingly pronounced with the second and third degree sprain and strain injuries. With the tendinopathies will have minor to major impact on activities of daily living depending upon the severity of the tendinopathy. Most examinees will experience minor impact on activities of daily living because the tendinopathy is in its early or minimal stages. And the classic finding of this type of tendinopathy is the examinee will report that they have pain on a specific activity, pain on some type of repetitive activity that generally resolves with a warm-up. And after the tendon and the muscle tendon unit is warmed up, then the pain will generally resolve, but then the next day the same cycle repeats over and over and over. Pain on specific activity that resolves with warm-up. Now, you can tell that the tendinopathy is progressing when the pain persists even through the warm-up, and the pain starts to spread from not only the specific activity, but into other more generalized activities as well. And as the pain starts to impact more and more activities of daily living, then the pain becomes what we refer to as having a major impact on activities of daily living. Now, one of the physical examination procedures that distinguishes very well between injury to the contractile tissues versus injury to the non-contractile tissues has to do with manual muscle testing or isometric contraction testing. With isometric contraction testing, because we are loading the contractile unit, we're going to see pain. The pain will be minor in the case of a first degree strain, but will become moderate to major with the second degree strain, and then with the third degree strain, because the third degree involves a rupture of the contractile unit, we're going to see generally no pain. Whereas with the non-contractile tissues, because there is no movement of the joint, or there's supposed to be no movement of the joint with isometric contraction testing, and by definition the term isometric means that there's no movement of the joint involved, these non-contractile tissues will not emanate pain. They will not emanate pain because there's no movement and no loading of the non-contractile tissues. With tendinitis and tendinopathy, the pain will range anywhere from minor to major, depending upon the severity of the degenerative process involved. And in most cases in the qualified medical evaluation, the pain reported by the examinee is going to be minor. It's going to be minor. You will rarely see complete weakness, grade 3 weakness due to tendinopathy. Now, because the contractile and non-contractile structures are sensitive to stretch, we're going to see pain on passive stretch of the first and second degree strain injuries. We're going to see pain on passive stretch of the first and second degree sprain injuries. But because the third degree strain and the third degree sprain injuries involve complete rupture, there will be no pain, because with complete rupture, there is no loading and no stretching strain imparted on the muscle or the ligament structure. On joint play testing, even though the AMA guides do not describe joint play testing, on joint play testing, we're going to see that with the injury to the contractile units, because the injury is not to the joint itself, all joint play testing will be normal and unaffected. Whereas with the sprain injuries, the injuries to the non-contractile ligamentous structures, we may see, in the case of a third degree sprain, we may see, of course, excessive joint movement because of injury to the passive restraint offered by a healthy and normal ligament structure. With the first and second degree strain injuries and the first and second degree sprain injuries, while there may be pain to palpation, there will be no palpable defect because there's no palpable separation of the muscle or the ligament structure. Whereas in the third degree sprain and strain injuries, there will be a palpable defect as your finger sinks into the deficit between the opposed ends of the injured muscle tendon or the injured ligament structure. There's no crepitus or sound emitted from the musculotendinous contractile structure or the ligamentous structure. But with tendinopathies, you may possibly hear crepitus as the tendon goes through excursion of range of motion. And the most common location to detect crepitus from the tendon is along the thumb flexor and extensor tendons in cases of de Quervain's stenosing tenosynovitis. Additionally, with tendinopathy, when you palpate the tendon, you may detect a palpable nodule, and this is commonly found in the gastrocnemius muscle, where the Achilles tendon is quite readily palpable. So this describes some of the positive objective physical examination and activities of daily living findings that would distinguish between injuries to the contractile units, which consist of the muscle and the tendon and their associated junctions, compared to the non-contractile ligamentous structures. So this type of physical examination algorithm will help you quickly arrive at a diagnosis as to whether or not your injury involves contractile versus non-contractile tissues. So now that we know the difference between injury to the contractile and non-contractile tissues, let's turn our attention now to positive physical examination findings in the range of motion and manual muscle testing examinations of the spine, of the upper, and of the lower extremities. So when you think about your active range of motion testing and you visualize in front of you an examinee who has limited active range of motion, what are some of the things that can limit active range of motion? Well, there's many things, of course. The most common of which that we're going to see is due to pain. Pain, of course, can limit the examinee's ability to go through full excursion of range of motion. Also, because active range of motion involves active contraction of muscles in and around the joint, any muscle weakness can produce a decrease in the active range of motion. Paralysis, spasm, and tight or shortened tissues can also reduce active range of motion. With tight or shortened tissues, this often produces what's known as a lag in the excursion of the range of motion. And the AMA guides give particular emphasis in the lower extremity to an extension lag at the knee. Extension lag at the knee is often due to tight or shortened hamstring muscles or tight or shortened posterior capsule, generally following either an injury or generally following a surgical procedure. That's referred to, at least in the lower extremity, as an extension lag. Altered length tension relationships of muscle can affect active range of motion. Modified neuromuscular factors can affect active range of motion. Modified joint muscle interactions, such as total knee replacement, which changes the axis of rotation of the joint and the leverage angle of pull of the quadriceps muscles. These are all things that additionally can impact active range of motion. Now, as an examiner, as you take your examinee through active range of motion testing, you want to separate out and make a clear distinction between examinee's subjective responses and your objective observational findings on active range of motion testing. So here's some things that you can focus on that will give you a good understanding as to what is the true cause of the examinee's limitation to active range of motion. Number one, you want to pay attention to where pain occurs in the arc of movement. So, for example, a good example of a painful arc is found in the shoulder. Pain in the shoulder, particularly with shoulder abduction. Pain occurring between 60 and 100 degrees of shoulder abduction. This is known as a painful arc, and this is a common objective physical examination finding in cases of subacromial impingement syndromes. So these painful arcs are well established and well known and may serve as a true positive physical examination finding in the presence of an examinee's report of painful arc that's consistent with known painful arc findings associated with that particular joint. You want to pay particular attention for any change in quality or intensity of the pain as the examinee goes through the range of motion. Except in cases of fracture or tumor, bone pain generally does not change with movement. So bone pain would be consistent throughout the entirety of the range of motion, whereas muscle pain, the contractile tissue pain, and the non-contractile tissue pain may have positions of pain throughout the range of motion and may have pain-free sections throughout the range of motion. You want to pay particular attention to the examinee's reaction to the pain, because this is the examinee's pain behaviors can serve as true positive physical examination findings, and the examinee's reactions to pain give you an idea as to the impact of the pain on the examinee, and also gives you an idea of the examinee's pain threshold. So this will also allow you to assess the examinee's consistency throughout your physical examination, such that if the examinee reacts wildly or vehemently to certain physical examination maneuvers with reports of great pain, whereas on other physical examination maneuvers that stimulate and activate the same or similar tissues, and the examinee reports minimal or no pain, that would be an example of an inconsistent physical examination finding. You want to pay attention for the examinee potentially or possibly incorporating accessory muscles or substituting muscles that would normally not be involved in performing the range of motion, now recruiting or incorporating those muscles in order to accomplish the range of motion. This serves as a true positive physical examination finding. This is commonly seen in active range of motion testing around the shoulder, where the examinee can recruit the trapezius and the interscapular muscles to substitute for painful and dysfunctioning rotator cuff muscles that would otherwise perform the same or similar joint action. So examinee incorporating accessory muscles constitutes a true positive physical examination finding. In cases where the examinee has normal and full active range of motion, you can further assess the function of that joint by applying overpressure and making an assessment of the end feel. And there are many types of end feel, and some types of end feel are painful, whereas other types are not painful. So a little bit of gentle overpressure at the end of range of motion. And when you have pain-free overpressure in the presence of full active range of motion, that would be considered a normal range of motion finding for that particular joint. Now, in testing active range of motion of any particular joint, you want to accompany your active range of motion testing with passive range of motion testing. And passive range of motion testing can be a great source of positive objective physical examination findings as well. Now, the purpose of passive range of motion testing is to determine the available anatomic range of motion and compare the available anatomic range of motion with the examinee's physiologic range of motion that they give you on active range of motion testing. Remember that the anatomic barrier to passive range of motion testing is always greater than the physiologic barrier. So the passive range of motion should be greater than the physiologic examinee active range of motion. And passive range of motion can be classified as either normal passive range of motion, hypermobile passive range of motion, or hypomobile passive range of motion. And when you see differences between active range of motion and passive range of motion, you ask yourself, well, what's the cause of this discrepancy? And the discrepancy can be due to any combination of muscle contraction or spasm, can be due to muscle deficiency, can be due to neurologic deficit, can be due to contractures, which would limit both passive and active range of motion. And most commonly in the industrial setting, the difference between active and passive range of motion that limits active range of motion but does not limit passive range of motion would be due to pain. Generally, the pain is due to injury to the contractile musculotendinous structures, whereas passive range of motion does not involve or employ the musculotendinous structures. The examinee will have much greater passive range of motion than active range of motion. When you identify joints that have either hypermobile or hypomobile passive range of motion, you want to compare the examinee's injury to the types of injuries that these particular pathologic ranges of motion predispose the examinee to. So, for example, hypermobile joints are susceptible to ligament sprains. Those are non-contractile ligamentous sprains. They're susceptible to joint effusion, and this may be something that you would see by observation, and this was something that would serve as a true positive physical examination finding. Hypermobile joints are subject to recurrent injury and chronic pain, and because this hypermobile joint represents an unstable joint, you're going to see findings of tendinopathies and peritendinitis. And this is due to the overload placed upon these tendinous structures that cross the joint in an effort to substitute tendinous stability for ligamentous instability. And because these are unstable joints that are sometimes flail joints and overly mobile joints, these are going to be subject to early osteoarthritis, and this is something that would produce true positive physical examination findings that you could see with your naked eye. On the other hand, hypomobile joints are susceptible to muscle strains, they're susceptible to pinched nerve syndromes, and they're also subject to tendinopathies and peritendinitis resulting from overstress on the contractile muscle tendinous structures due to an otherwise hypomobile joint. And because in the industrial setting and the qualified medical evaluation, because we're going to see more circumstances of hypomobility than hypermobility, it's important to understand some of the different causes of hypomobility. So one type of hypomobility is due to changes in the myofascial structures due to adaptive shortening or hypertonicity of the muscles, or from post-traumatic adhesions and or scarring. This is commonly seen following total knee replacement surgery, where the hamstring muscles become adaptively shortened, and we developed adhesions and scarring in the posterior capsule of the knee joint itself. And sometimes these examinees, no matter how much physical therapy they participate in, they are not able to avoid this adaptive shortening or the development of post-surgical adhesions, and they never really regain full range of motion of their knee. And the AMA guides provide for permanent impairment for this under the section related to the results from knee replacement surgery. And this is what we identify as a positive physical examination finding, known as extension lag on knee range of motion testing. Another type of hypomobility is known as pericapsular hypermobility. Results from adhesions, scarring, arthritis, arthrosis, fibrosis, or tissue adaptation. This is commonly seen in the frozen shoulder syndrome. And then finally, a third type of hypomobility is known as pathomechanical hypomobility, and this results from joint trauma, either microtrauma or macrotrauma, leading to restriction in one or more directions. And this is differentiated from the other types of hypomobility because this one involves direct trauma and injury to the joint itself. And this will typically be associated with its own true positive physical examination findings in and around the joint itself. Finally, the second category of physical examination procedures that we commonly employ in our physical examination of the spine and also of the upper and lower extremities involves manual muscle testing. And the AMA guides describe manual muscle testing in each of chapters 15, 16, and 17. So the purpose of manual muscle testing is to test the contractile musculotendinous tissues to determine the integrity of the contractile tissues. Now, because we're employing contractile tissues, we're also testing the nerve supplying the contractile tissues. So weakness on manual muscle testing can involve injury or dysfunction of the contractile tissues, and also can involve injury or dysfunction of the nervous tissues. So weakness may be caused by upper motor neuron lesion, by injury to a peripheral nerve, by pathology at the neuromuscular junction, by a nerve root lesion. Those are all nervous tissues. And then also can be caused by injury to the end organ itself, such as lesion or disease of the muscle, by lesion or disease of its tendon, or by lesion or disease at the bony insertion themselves, such as an enthesopathy or an avulsion type of injury at the bony insertion. And then also, and you need to pay ever attention for those cases where the weakness has to do with non-physical or non-organic findings, including psychologic overlay. Now, many times when we do our manual muscle testing, the examinee will report weakness due to pain. Well, the AMA guides discount or disqualify weakness due to pain, but weakness that is not associated with pain is a positive neurologic sign indicating that a nerve root, a peripheral nerve, an upper motor neuron, or a neuromuscular junction is at least part of the problem. And the reason that there's no pain is because in these cases, the contractile structures, the muscle and the tendon, are normal, but the contractile structures are weak because they're getting poor neurologic supply due to injury to the neurologic structures. So with manual muscle testing, there's a few combinations of findings on physical examination that will help direct our attention to the structure injured. So for example, in examinees who produce strong manual muscle testing, in other words, the muscle testing is strong and pain-free, that tells you that there's no lesion of the contractile or nervous tissue, and neither of those are the source of the examinee's pain or discomfort. The contractile tissues are normal, the nervous tissues are normal. The examinee is able to produce +5 resistance in the absence of pain. This is considered a normal or a negative finding with no injury to the contractile tissue and no injury to any of the nervous structures. On the other hand, an examinee who has preserved strength but who reports pain, this is due to a local lesion of the muscle or tendon, such as a first or second degree strain of the tendon, and it's the contractile tissue that's complaining during the test procedure. This indicates that the neurologic structures are functioning properly because the examinee is able to produce good strength. Examinees who provide a weak response to manual muscle testing, also in the presence of pain, this tells you that there's some lesion around the joint, such as a fracture, and the weakness is due to reflex inhibition. And remember, the AMA guides tell us that in the presence of pain, findings on manual muscle testing are disqualified and do not qualify for permanent impairment. On the other hand, manual muscle testing that is weak and pain-free, this does qualify for impairment according to the AMA guides, because when the examinee is weak and provides testing in the absence of pain, this tells us that there's a bona fide injury, such as a rupture of the muscle, such as a grade 3 strain, or its tendon, or involvement of the neurologic structures, such as a spinal nerve root or the peripheral nerve that supplies the muscle, and it's this category that qualifies for permanent impairment. So these are some typical patterns that you will see. The examinee will be strong with no pain. The examinee will be strong but reports pain. The examinee will be weak and reports pain, or the examinee will be weak in the absence of pain, and only one of these four, according to the AMA guides, qualifies for permanent impairment. So doctors, I hope this helps you. In the spine, in the upper extremities, and the lower extremities, we're going to see injuries potentially to contractile tissues, to nervous tissues, and to inert or non-contractile tissues. Each of these are going to be associated with their own true positive physical examination findings. Now, of course, the grade 1 injuries to both contractile and non-contractile tissues will have minimal or no impact on activities of daily living and will have minimal or normal physical examination findings, whereas the grade 2 and grade 3 injuries are going to start to have progressively more impact on activities of daily living and progressively more observable true positive physical examination findings in your physical examination of the examinee. And this discussion on the joint examination simply serves to reinforce one of the principles that we talked about in session 1 of this program. And that is, pain, by definition, according to Merriam-Webster's dictionary, is characterized by what they refer to as evasive action. Evasive action. And the true positive physical examination findings with all of these injuries, whether we're talking about contractile tissues, inert tissues, neurologic tissues, the true positive physical examination finding consists of some form of response to the pain. And the response to pain that you can pick up and that constitutes the true objective finding is the evasive action away from the pain. So When examinees report pain on physical examination procedures, whether you're doing range of motion testing, whether you're doing manual muscle testing, whether you're doing neurologic testing, the examinee will evade or move away from the pain. And that's what constitutes the true positive physical examination finding. Now, this is important for our purposes because recent studies indicate that in California, injured workers go on to receive a permanent impairment rating in California, meaning that injured workers fail to recover to their pre-injury condition in California at a much greater rate than any other state in the United States. In fact, California ranks dead last in 50th place out of 50 states in the rate at which examinees go on to receive a permanent impairment rating. Why is this? Well, it has nothing to do with the severity of injuries, because the severity of injuries in California are no more severe than the severity of industrial injuries in Texas versus North Carolina versus New Hampshire versus North Dakota. Industrial injuries are the same nationwide. But it seems that in California, we fail to understand the true positive objective physical examination finding, and this results in an overstatement and an overrating of the examinee's permanent impairment rating. So it's important to understand what constitutes the true positive physical examination findings upon which your permanent impairment ratings and your opinions and conclusions for permanent impairment are going to be based. And the purpose of this program is to give you some insight into what constitutes the true positive physical examination finding. You know, true positive physical examination findings are in front of us and in our face the moment that we lay eyes on the examinee. And we gather true positive physical examination findings or their absence through our eyes. And in particular, our eyes should be trained to focus on the evasive action, because the evasive action is the true indicator of pain that impacts activities of daily living. Now, in the absence of an evasive action from the examinee, does that mean that the examinee does not have pain? That does not mean that the examinee does not have pain. The examinee could still have pain in the absence of an evasive action, but that gives you an understanding as to the severity of the examinee's pain. An examinee who does not demonstrate evasive action is reporting minimal pain only. In the AMA guides, just like our prior 1997 permanent disability rating schedule, the AMA guides do not provide for permanent impairment for minimal pain. So examinees that do not demonstrate evasive action are demonstrating minimal pain only, and minimal pain does not qualify for permanent impairment. Only examinees that have true positive physical examination findings and true impact on activities of daily living qualify for a permanent impairment rating. And I hope this is a principle that you will consider at great length and take to heart with your very next examinee. So this is Dr. Perry Carpenter. I want to thank you for taking the time to join me on this program, the Orthopedic Essentials for the Qualified Medical Evaluator. I look forward to being with you on future programs as well. And for now, I'm wishing you best of success in your career as a qualified medical evaluator.